Hi, my name is CJ. I'm the nurse that's going to be doing your gastrointestinal exam. Can you tell me your name and date of birth?
Quinn Graham, October 13th, 2005.
All right. So when you first walk in, you're going to just notice his appearance. So is he guarding his stomach? Because people that are have really bad stomach pain are going to be guarded or tense. Sometimes they may even hold a pillow up against. He's not. He's relaxed. And then you're just going to look here for symmetry. You see if there's any masses, lesions. People that are bigger will have striae marks to show weight gain or weight loss. He has no striae. You're also going to look at the umbilicus. If it's super inverted, inverted, that also can mean obesity. His is normal, within normal limits. It's not everted. If it's everted, sometimes that's indicative of fluid excess under the abdomen, as well as gas that can also invert the umbilicus as well. You're also going to look for any types of hernias down here around the umbilicus. He's got no hernias. All right. After you look, you're going to then acoustulate, auscultate. You'll auscultate. You want to auscultate before you percuss or palpate, because palpation and percussion can increase gastric mobility and stuff, so we're not going to be getting an accurate read. So I'm going to listen to all 4 bowel quadrants, and you're going to listen for, if you don't hear any sounds, you'll have to listen to each quadrant 5 times. So that's a total of 20 minutes. So to say that a quadrant does not have bowel sounds, you gotta sit there and listen for a very long time. So you're gonna take your stethoscope, you're gonna use the diaphragm. You can warm it up with your hands so it's not as cold. And you're just gonna spend time and listen. Yours are very hyperactive. It's probably because he has not eaten as much today, so he's a little hungry. Good. And you want to hear bowel sounds, you usually hear the first sound within 5 to 10 seconds. His are definitely more hyperactive, and I'm hearing them probably every 1 to 2 seconds, which again is not bad. Just means that his bowels are working. So, and then you're also going to listen, if I could have you lay down. You're going to also listen for the aorta. So sometimes on really skinny people, you can actually see the aorta pulsating. You can actually see his pulsating a little bit. I guess you guys can't really tell. But it's going to be just left of the midclavicular line. And you're going to listen to that with the diaphragm, or the bell. Listen for bruits. Yeah, I hear no whooshing sounds at all. If you hear any whooshing sounds, that will tell you that the patient may have a bruit and aortic stenosis somewhere in the abdomen. Next, we're going to percuss. So we'll first percuss the liver. Usually they don't do this as much anymore. Studies have shown that it's an inaccurate measurement. But the liver, if you remember from anatomy, is going to be on that right side. So, I'm going to warm up my hands so they're not as cold. So stay as relaxed as possible. Good. And you're just going to percuss. So, you're going to do the same percussion technique that you learned with the respiratory system. So I hear a dull sound right here around the 11th and 12th rib. And then you're also going to percuss, you're going to find, that's dull. Listen for a dull sound. There we go. So the top of the liver is right around the 5th midclavicular line. And then it goes down all the way into about the 11th or 12th. That's about probably 4 centimeters, which is a healthy liver. anything that's larger and the liver goes down towards past the 12th rib will show that the liver is actually enlarged. And then if it's enlarged, I would refer them to a CT scan, see what's going on. And then you're also going to do the spleen, which is going to be on the left. And it's going to be around the 11th and 12th rib. You're going to just, I don't hear any dull, I just hear tympany. If you heard a dull sound, that will tell us that the spleen is enlarged and he has splenomegaly. If you remember from med-surg classes or any other class, like mono will actually enlarge the spleen. So then I would do further testings regarding like maybe he has a sore throat or his tonsils are enlarged to figure out what's causing that spleen to be enlarged. And then you're just going to just do it around the abdomen, do all 4 quadrants. And you're listening for tympany. So if you hear dullness, that's going to be an organ maybe enlarged, or there's going to be some sort of swelling or fluid buildup. Also, if you hear hyperresonance, that shows us that maybe it's gassy somewhere. You can also percuss right around the bladder line, see if he has a full bladder. For those that have urinary retention, it's a good method to see if they have a full bladder or not. And then, lastly, we're going to palpate. So first, we're going to just start off with a light palpation. Just use your fingers. Any tenderness, pain? No? Good. You're going to feel for some masses and lesions. Just go 1, maybe 2 centimeters deep, and that's it. And then we can also palpate for the liver. So we go back to that right side. Relax. Relax. And then take a deep breath in. Keep relaxing. Good. And then out. So actually, you could feel, I felt a tiny little bit of the edge of the liver. When the patient takes a deep breath in, the diaphragm pushes the liver down, so it makes it easier to palpate. So then you can feel for kind of that edge. If you feel more than just a little bump, a little edge, and you feel the liver down here, again, that's going to show you that his liver is probably enlarged. We're also going to do the same thing with the spleen. Deep breath in. Good. So I can't feel the spleen at all. If you can feel the spleen, that's again splenomegaly, and we need further testing. Okay. Also, you can test for cholecystitis. So if you can take it, that's again inflammation of the liver. So we're gonna go back to the liver side, and he's gonna do the exact same thing, and he's just gonna tell me if he feels any sort of pain. So deep breath in. Any pain?
No.
Good. So patients that have cholecystitis, they can only inhale a little bit before it becomes too painful. So if he had pain when he inhaled, that's going to tell us that he has cholecystitis. All right, and then we're going to do some deeper palpation. So this is going to go probably about 3 to 5 centimeters. You can even probably go deeper. And you're just, again, listening for some more masses and lesions. Any points of tenderness. Make sure to get all 4 quadrants. Good. Any pain?
No.
Good. And have the patient try to relax as much as possible, because sometimes if they tense, you're just going to get straight abs. So he needs to relax a little bit more. But he had no pain or tenderness. Next we can test for fluid volume. So I'll have Quinn put his hand midline.
Like that?
No, just do the ulnar, or this, open your hand. There we go. And then you're just gonna have your hand on the far side and then just tap. you should not feel any sort of vibrations on the other side. You can also, if they do have ascites, you can actually see the fluid kind of ripple all the way across, and you'll be able to feel the vibrations on the other side. He has no fluid volume accumulation. Fluid volume accumulation, if the test was positive, will show that he probably has some sort of liver issue like cirrhosis. You can also do another test. What's it called? I have to look at it. The shifting dullness. So you would percuss and find an area that's dull and mark it, and then you have the patient lay on their side this way, and then or the other way, and you're gonna percuss again and see if that shifting dullness has shifted to a different side. That will show that the fluid has moved. And to confirm it, you just have the patient lie supine again and see if that fluid goes back to where it was originally. You can also test for appendicitis, and you'll use McBurney's point, which is in the right quadrant, and you just ask if there's any pain associated with any of this palpation or pain when I lift up. Any sort of pain?
No.
Good. So that will show that his appendix is not inflamed. If it was inflamed, it would be super tender. Also, if when I release, there would be some sort of rebound tenderness, and it would be super painful. You can also check for rebound tenderness in other areas. So if I would lift up rapidly and he was in pain, that's going to be like, we'll have to do further testing, maybe get a CT scan to see what's going on in there. And then I think that's just about it. All right, thanks, Quinn.